That's not okay. You can go ahead.
Okay, good morning, teachers and colleagues. I'll be presenting the April 2022 practice question 2B. Next slide, please. Okay, a 32-year-old medical officer in your hospital emergency department with history of fever of 2 days duration, associated generalized weakness. He took artemether, lumefantrine, and NSAIDs with no relief. He developed cough and took amoxicillin clavulanic acid, still with no relief. 2 days, he noticed headaches, sore throat, tingling sensations in the ear, and a rash. A colleague asked you to see him to sort him out. 1. Mention 4 other questions you'd like to ask him. List 4 differential diagnoses. What is the most likely diagnosis? 4. What are the risk factors for acquiring this disease? 5. What is the vector and mode of transmission of the disease? 6. How will you investigate the patient? 7. How will you manage him? 9. List 4 complications. 8. List 4 complications, and 9. What are the prognostic indices? Next slide, please. Okay, so I want to ask him other questions like history of vomiting, passage of loose stool, the quantity, the number of episodes of loose stool, if there's blood in the stool. I want to ask about redness of the eye or yellowness of the eye. I want to ask about passage of dark colored urine and if there's reduced urine output. I want to ask him about contact with person with similar symptoms, which is most likely because the person is a medical officer at the casualty unit of the hospital. I also want to ask about bleeding into the skin or from any other craniofacial orifices. Next slide, please. These 4 differential diagnoses, my first diagnosis will be that of differential diagnosis will be that of Lassa fever infection because he lives in a Lassa fever endemic zone. Then he's a medical officer that works at the casualty with history of fever and treatment for malaria, which and with still the persistence of the fever and history of cough. Then with the history of rash and sore throat and tingling sensation in the hair. My second differential will be that of streptococcal pharyngitis because of the history of fever and sore throat. I would also think of community-acquired pneumonia because of the history of fever and cough. And I'll think of sepsis because of the fever, cough, and rash, the persistence of the symptoms despite treatment with anti-malaria and antibiotics. Next slide, please. What is the most likely diagnosis? I'll think of Lassa fever infection because of the symptoms I stated earlier. Then question 4, what are the risk factors for acquiring this disease? Being a resident in an endemic area like Nigeria, Sierra Leone, Senegal are one of the risk factors. Then visit to an endemic area is also a risk factor for acquiring the disease. Then exposure to the vector. The vector of Lassa fever virus is Mastomys natalensis, and it's a multi-mammate rat. Usually exposure to the vector either by coming in contact with the feces or droppings of the rat or eating the rat directly could predispose an individual to acquiring the infection. Also, being a staff of the hospital is also a risk factor for the infection. Then improper infection control measures like not properly washing the hands, not observing the precautions, the general precaution in taking care of patients. Question 5, what's the vector and the mode of transmission of the disease? Like I said earlier, the vector is Mastomys natalensis, and it can be spread either from rodent to man or from human to human. From rodent to man will include contact with urine or dropping of the vector, coming in contact or eating contaminated food by the vector, can also be contacted through inhalation of aerosolized particles from the rodent excretion or by eating the rat. Some people have habits of eating rat. Then it can be transmitted from human to human by contact with infected body fluid, tissue, excretions, and contaminated medical equipment, which most likely would have happened in the patient being discussed because he works in the hospital. How will you investigate this patient? I want to do a Lassa fever reverse transcriptase PCR. This usually has a higher yield than the ELISA for antigen or hemoglobin M. I would also want to do a full blood count, in which I will likely see the patient will likely have a low PCV, and the platelet may also be reduced because Lassa fever causes endothelial dysfunction. Then I would want to do a liver function test, in which the liver enzymes like the AST, ALT would likely be elevated. Then the bilirubin would also be elevated because it causes hemolysis. I want to do a urinalysis also in this patient. Most likely patient is likely going to have a presence of blood in the urine. I would also want to do a random blood sugar to be sure the patient is not a non-diabetic patient, or the patient might not have been eating well. Patient can present with hypoglycemia. I would also want to do an electrolyte urea and creatinine. Lassa fever infection is nephrotoxic, and it could even cause either perennial or renal failure, intrinsic renal failure itself. So most likely it could be a reduced bicarbonate because of metabolic acidosis. There could also be an elevated urea and creatinine. I want to do a pregnancy test for women because Lassa in pregnancy usually portends a poor prognosis, and there's a risk of having stillbirth in the patient. I want to do a blood culture because patient could have secondary bacterial infection. So a blood culture will help to identify the organism and treat appropriately. Then I want to do a clotting profile in this patient, the PT-PTK-INR, which may be elevated, especially if the patient has DIC. How will you manage the patient? My goals of management would be to resuscitate the patient, to offer supportive care, and to give antiviral embolization, then also to identify antiviral agents like ribavirin. I would want to identify and treat complications and follow up and counseling. I want to resuscitate the patient by making sure that the airway is patent, patient is breathing appropriately, and I will ensure circulation. Then I would want to offer supportive care by giving appropriate fluid. I want to rehydrate properly, at least 3 liters per day, depending on if the patient has developed AKI or not. I want to ensure that the electrolytes are balanced or correct. If they are not, I want to offer oxygenation for patients that have the pulmonary form of pulmonary complication of Lassa fever, usually by inhalation. I want to place on intranasal oxygen and monitor the SpO2 appropriately. Then I want to give antibiotics for secondary bacterial infection. I want to ensure adequate input and output. Then I want to give ribavirin therapy. Ribavirin is an antiviral nucleoside agent, and it's best used within the first 6 days of the infection. The prognosis is better when it's used within the first 6 days of infection. There are quite a number of regimens. There's a McCormick regimen and there's a Irua regimen. One can give 33 milligram per kg start.
Hello.
Hello. Hello. Okay, one can give 33 milligram per kg start, then a maximum of 2.5 gram, then followed by 16 milligram per kg, 6 hourly in the first 1 to 4 days, then followed by 8 milligram per kg till the 10th day. I want to identify and treat complication in these patients. For a patient that has AKI, I want to offer conservative management, or if it fails, I want to offer dialysis. Then for patient with pulmonary complication, I may want to admit in the ICU and infectious disease ICU and treat appropriately. For patient with disseminated intravascular coagulopathy, I would want to give fresh frozen plasma and treat. Then the next line is to follow up. I want to counsel the patient. After 10 days, I want to repeat the Lassa fever PCR. If it's positive, if it's positive, depending on the viral load, I may discharge the patient and place the patient on 500 milligram ribavirin 3 times daily. Then I'll ask the patient to come back again for a repeat test after 10 days. Usually the viral load reduces after like 10 days. Then I want to counsel the patients that getting infected with Lassa fever virus does not offer a long life protection, as patient can still get infected subsequently. Then I want to advise, if this patient is a male, I want to advise him to use protection, because the virus will still be in his semen for the next 64 days, and he could still transmit the virus to his partner. Next slide, please. Then list 4 complications of Lassa fever. Complications include acute kidney injury, disseminated intravascular coagulopathy, stillbirth, deafness, anemia, and encephalopathy. Next slide, please. Next slide. The next question is, what are the prognostic indices? Pregnancy is a poor prognostic index. Also, the presence of poor prognostic index. Also, presence of encephalopathy, presence of shock, late commencement of ribavirin. Ribavirin gives the best response when it's given up within the first 6 days. If it's commenced afterwards, there's a likelihood that the prognosis will be poor. Then extreme of age, like less than 5 years or greater than 50 years. Elevated serum AST, or when it's 150 IU per mil. Then presence of seizures, altered sensorium, and acute kidney injury are poor prognostic indices in the patient. Next slide. I don't know. I want to go through just a short presentation on
Can you
Lassa fever.
can you just give us highlights so that
Okay,
we
let
can
me give you.
discuss? We don't have all the time.
Okay. So Lassa fever virus belongs to the Arenaviridae family, and it's endemic in some part of West Africa. It's commoner in dry season, and it was first discovered in Lassa village in Borno, northeastern Nigeria, when 2-3 nurses were working, and one of them got infected, and some of them eventually died, and one of them was flown out of the country. And eventually, that's the one that was flown out of the country was isolated, and the blood sample was taken, and the virus was isolated, and it was discovered, and it was named after the village, that's Lassa village in Borno. And it's not the only viral infection with other hemorrhagic manifestation. There are some other viral hemorrhagic fevers, like the yellow fever, the dengue hemorrhagic fever. Then the filovirus group, which includes the Ebola and the Marburg virus, are also viral hemorrhagic fever. They are all in my slides. Like I said earlier, the mode of transmission is through rodent to human or human to human transmission. And the summary of the pathogenesis is that the virus, an individual acquires the virus and it invades the dendritic cells, and it causes paralysis of the cellular antiviral response, leading to dysregulated co-stimulation and uncontrolled activation. It leads to release of cytokine, what is called cytokine storm, like what happens in COVID-19 infection, and there's release of tumor necrotic factor alpha, interleukin 6, and also it invades the hepatocyte, leading to liver dysfunction, inhibition of clotting factor synthesis. It invades the adrenal cortical cells, leading to hypotension and metabolic disorder. This can progress to cause shock and multi-organ failure. The early manifestation, just like most viral hemorrhagic fever, it could be general. Patient can have fever, chills, malaise. Patient can have gastrointestinal signs. Patient can have respiratory symptoms. Patient can have neurologic symptoms also. Then hemorrhagic symptoms like petechial rash, erythema, and at the late stage, patient can have shock, convulsion, delirium, coma, and the likes. And high index of suspicion is essential in making the diagnosis. And Lassa virus reverse transcriptase can be done, or the enzyme-linked immunosorbent assay. I've listed the investigations that can be done and the supportive care of treatment. The ribavirin is a nucleoside analog, and it's more effective when it started within the first 6 days of illness. For a woman that is pregnant, the risk needs to be weighed. The risk and benefit needs to be weighed, and though it may be warranted in order to protect the mother, and it does not reduce the severity or incidence of deafness. This is a picture trying to show the different kind of regimen that can be used for patients. Then, if at day 10, if a patient is still having symptoms and signs, one could consider other co-infection. And if fever persists for 72 hours following after day 10 of treatment, patient could be discharged on oral ribavirin. And the dose of oral ribavirin needs to be adjusted by half, especially for patients with renal dysfunction. And ribavirin toxicity itself can cause anemia, asthenia, headache, anxiety, abdominal pain, diarrhea, and vomiting. I've mentioned the poor prognostic index, and there's some consideration for post-exposure prophylaxis in with ribavirin, especially when the individual has come in contact with the patient. Such a patient should also such an individual should also be monitored for about 21 days. Also, then a prophylactic regimen for ribavirin is 500 milligram by mouth every 6 hourly for 7 days. There's a new antiviral agent, that's favipiravir, that was initially used for the treatment of Ebola, and it has shown synergistic activity in vitro against Lassa virus, especially when it's combined with ribavirin. These are the differential diagnosis, and majorly prevention and control of Lassa is very important. There should be use of PPE and hand hygiene, especially when one is taking care of patients with Lassa fever. Then there's a proper way of donning and doffing the post-exposure prophylaxis, and we should be properly trained on how to do such. In conclusion, Lassa fever is a multisystemic viral infection, and it's characterized by immunosuppression, generalized vascular damage, and impaired coagulation. Can present with constitutional symptoms and signs like the patient described in the question presented. An aggressive advanced supportive care and treatment with ribavirin is a hallmark of management. Safety of healthcare workers and prevention of further transmission is important in curbing the spread of the virus. Thank you very much.
Okay, thank you, Dr. Adebimpe, for your presentation. Dr. Alex, you can go back to the question slide while people start. Participants can make comments, contributions. You can type in the chat box. Okay, Dr. Success, you can go ahead.
Okay, good morning, senior colleagues and our teachers. Thank you so much, Dr. Pimpe, for that lucid presentation. Before I make my comment, I just want to ask you a question. You know, when we are dealing with all these diseases that have very important, social or epidemiologic or public health importance, there are definitions we use to actually know, in those cases. For example, we have an alert case, suspected case, confirmed case, probable case. In this, your patient, using case definitions, how will you classify this patient? Is it a suspected case or a probable case or an alert case?
Okay,
Hello,
thank you
people.
for. Yeah, I heard you. I heard you, Dr. Success. Okay. For this patient is a suspected case. There are actually well-defined criteria as released by the NCCDC for management of patients with Lassa fever and the case definition. This patient is a suspected case of Lassa fever infection. I would try to get the case definition guideline and forward it to the page. Or you make a definitive case of Lassa fever usually when patients have symptoms alongside with features of complications like shock, acute kidney injury, and patient is resident in an endemic zone. You make it as a definitive case. While suspected case is like this scenario that was painted by in this question, which patient has features as used drug and history of exposure because it works in the emergency. So I think this is a suspected case. While a probable case is when there's history of contact also, and the symptoms are not really clearly defined. I'll try to get the NCDC definitive diagnosis and put it on the page. Thank you.
Okay, thank you so much, Dr. Pimpe. I just wanted to add that it's important that these case definitions are added to your slides. Because, for example, a case, suspected case is a case of a patient that has fever, okay, between less than 21 days with fever, and any of the following: vomiting, diarrhea, sore throat, abdominal pain, and myalgia. Now, when a patient is a suspected case, okay, in this case, we have done the laboratory test, that's the PCR, okay, that's in centers that have it. And they are usually classified into the wet and dry categories. Okay, so patients that are wet, fall into the wet categories. They have, they produce the effluents like bleeding, vomiting, diarrhea, coughing and sneezing. Why those that are dry are the ones without, all those influence. Okay, so they are dry. I wanted to also add that incubation period is 5 to 21 days. And usually for diseases like this, that have public importance, public health importance, apart from we, the clinicians, trying to prevent it, it's also important that we do the general, general prevention, such as telling the patient that, this is caused by a rat, and as much as possible, we should employ measures should employ, to keep rats or rodents away from the house. It's important to stress, personal hygiene. They should store their grains properly, improve in rodent-proof containers. It's important they dispose garbage properly, especially far from home, and of course, it's important for all them to also know that there's currently no vaccine, against Lassa fever. So prevention is key. Then finally, I want to say that the mortality from Lassa fever is about 1%. Okay, so it's important for these patients to also know that as much as possible, if they have this, especially in endemic zone, okay, when ribavirin is started early, it portends a better prognosis. So that's what I just wanted to chip in. Thank you so much. Thank you.
Thank you, Chief.
Yeah, thank you, Dr. Success, for a wonderful contribution. Dr. Yahaya Mohammed is saying infectious mononucleosis is a very important differential diagnosis in this patient. Dr. Ekele says the ribavirin is given via the IV route. Termination of pregnancy is one of the ways to manage Lassa fever in pregnancy. Other viral hemorrhagic fevers are also differentials. Please, how do you manage bleeding in Lassa fever? That's a question from Ekele Robert. Dr. Jafar said most cases are asymptomatic, 80%, or mild, but can cause severe disease. Seasonal outbreaks occur during the dry season, typically from December to April, from activities like bush burning, preparation of farmlands. So you can go ahead and answer Dr. Ekele. How will you manage it?
Okay, thank you for the questions and comments. For a patient with Lassa fever and with bleeding diathesis, alongside the supportive care, I would want to give fresh frozen plasma to the patient. I would want to give up to like 5 pints of fresh frozen plasma. Also, I want to offer the regular supportive care to the patient also, and also the ribavirin, intravenous ribavirin. And bleeding diathesis is a poor prognostic factor for the patient. Thank you.
Okay. 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 Even though I don't understand what Dr. Emmanuel is saying here. So are you saying Lassa fever is sexually transmitted disease? I don't think anybody's mentioned that. Or did you?
No, I did not. What I said is that for men, it persists in body fluids like breast milk and the semen for more than 64 days. So the patient needs to use barrier protection.
Any other question? Any other clarification? Can COVID also be a differential here?
Yes, because of the fever and the cough, and also because the individual is a health worker. Yes, it's a differential. Thank you.
Any other comments or contribution? Can you share your slide, Dr. Alex, so that Dr. Alagbe, are you ready for us?
Thank you, Dr. Alex, for helping out.
Yeah.
So more comments, more contributions. Okay, Dr.
I'm
Jafar is
sorry.
saying that there is a Lassa vaccine at phase 2 trial. Okay, Dr. Soxley, you want to say something?
No, I'm just being curious. Is Lassa fever a sexually transmitted disease? I'm just being curious. It is, because we said that, I don't know, because we said, I don't know, maybe the infectious disease people will help us, because we said the exposure to body fluids of an infected person is a risk factor. Okay, so of course, for sexual intercourse to take place, two persons have to be in contact. So I'm just thinking, is it really not a risk factor for acquiring this disease?
Dr. Adigbe, I think it's a risk factor.
Okay. I mentioned it that in the body fluids, it persists in the body fluids till especially semen for 64 days. Though the quantity in terms of the viral load may not be as much as as in the blood and other routes of transmission. So just to reduce the risk, there's a risk of transmission via sex. Let me just use that word.
Yeah. Exactly. Thank you.
Dr. Dalhatu, you want to say something? Dr. Dalhatu?
Yes, thank you for the presentation. I think it's a very good presentation. So about the transmission via sexual means, Lassa fever is not a sexually transmitted disease, but what she's emphasizing, which is correct, can be transmitted through sex, but it's not being classified as sexually transmitted disease. But all other things she mentioned, I think they are correct. Thank you.
So yeah, so Faye is saying, Dr. Faye is saying it is sexually transmissible disease, but not a sexually transmitted disease. Okay, any other question? Any other contribution from our teachers? So we'll go to the next presenter.
Dr. Thank you, Dr. The leader presented. Thank you. It was quite a lucid presentation. I love the way she answered the questions, and I must appreciate the participation from the class. So I think the participant and the presenter did a good job, really.
Okay.
So,
all right, Dr. Alagwe, you can go ahead.
Okay. Good morning, my teachers, my senior colleagues, and my colleagues. I'll be taking practice question 2B of the October exam. Sorry, my slide is not moving. Sorry, please. Let me just unshare and share again.
Okay. See, Dr. Alagwe, your slide is showing, are you still having a problem?
Yeah, I don't know. It's not moving. Sorry, please. And I tried it before it was. Okay, let me still go back. I'll share.
I hope you're sharing the screen.
My teachers, my senior colleagues. Good morning, my teachers, my senior colleagues, and my colleagues. I'll be taking practice question 2B of the October 2022. The question reads, a 45-year-old female with sudden onset of upper abdominal pain radiating to the back Worse with males, bilateral lower lung zone dullness, ascites demonstrable by shifting dullness, reduction in urine output, and periumbilical enchymosis. Oxygen saturation is 90%. What is the diagnosis? List 3 investigations to confirm the diagnosis. List 5 investigations to identify the underlying etiology and outline your management plan. So for the first question, it says, what's the diagnosis? I think the diagnosis here is severe acute pancreatitis. Based on the patient's presentation, the patient presented with a sudden upper abdominal pain that radiates to the back. Even though the parameters for assessing severity were not given, but the presence of bilateral lower lung dullness actually suggests that there's something going on in the respiratory system. And as we know, pleural effusion or infiltrate on chest X-ray is actually an indicator of severity. And then the presence of periumbilical enchymosis, which is also called Cullen sign, is also a predictor of high mortality. So I think this patient has severe acute pancreatitis. The second question says, list 3 investigations to confirm the diagnosis. One is serum lipase, and it's been said that if the serum lipase is 3 or more times greater than the upper limit of normal, it confirms the diagnosis. And normal serum lipase is usually less than 70. So once we're getting anything in the range of 300 units per liter, it suggests or it helps to confirm the diagnosis. And also serum lipase is more specific for acute pancreatitis because it's not secreted it's not seen in other conditions like serum amylase. Then the second one is also serum amylase, which also, once we find 3 or more times elevation, more than the upper limits of normal, also suggests it. However, there are other things that can increase serum amylase in a patient, like diabetic ketoacidosis and other conditions. So it's appropriate that you measure these two together. Then the third investigation is CT enhanced, contrast enhanced CT of the abdomen. Usually this is done in severe cases, moderate to severe cases, where it's going to help us delimit the anatomy of the pancreas, and it's going to help us to show us the type of pancreatitis the patient is having, whether it's the interstitial edematous or it's the necrotizing pancreatitis. And it will also help us prognosticate this patient. Then the third question says, list 5 investigations to identify the underlying etiology. One is abdominal ultrasound scan. As we know, the commonest etiology of acute pancreatitis is actually gallstones, which occurs in about 40 to 50% of patients. And abdominal ultrasound scan will help us pick this. But in cases where the gallstone is small, maybe when they are less than 3 millimeter, actually endoscopic ultrasound scan will help us better in picking microlithiasis. Then secondly, we want to do a serum lipid profile, particularly serum triglyceride. Hypertriglyceridemia is one of the causes of acute pancreatitis, and it has been shown that levels greater than 1000 milligram per DL actually is associated with acute pancreatitis. Then we want to do serum calcium because hypercalcemia is also a cause of acute pancreatitis. We want to do a full blood count plus ESR with a blood film because infections actually are also causes, viral infections, bacterial infection, parasitic infection. So for example, in parasitic infections, we'll be looking for eosinophilia. Then also in bacterial infection, we'll be looking for leukocytosis, neutrophilia, and then so this will also help us. Then also, if the cause of the acute pancreatitis is from alcoholic cause, we'll be looking out for microcytosis on the blood film. Then liver function test also. Liver function test will suggest to us if there's any intra or extrahepatic obstruction, which can be a cause of acute pancreatitis. And also, if it's due to alcohol, the AST to ALT ratio will be 2 to 1. Then endoscopic retrograde cholangiopancreatography. This is also a procedure that is diagnostic and is therapeutic for issues concerning bile stones. However, it's also a cause of acute pancreatitis, and it has been is a cause post this procedure. It can also cause acute pancreatitis, but also it can help us diagnose gallstones, any obstruction, and it can also help us treat the patient by stenting or removing whatever stone that is there. Then endoscopic ultrasound scan, I said, for idiopathic minute gallstones. Then serum IgG4 is usually elevated in patients that have autoimmune pancreatitis, so it's important we do it. Then genetic testing in patients that have cystic fibrosis and patients that have other genetic conditions that have been associated with acute pancreatitis. So the fourth question is outline your management plan. So principles of management, actually management of this patient is multidisciplinary, and it involves the gastroenterologists, the interventional radiologists, the ICU nurses, depending on the severity, and other personnel in the hospital. So when the patient presents, we know part of management, we want to take a proper, adequate history. But in this patient that we think it's a severe acute pancreatitis, we want to do everything simultaneously. So we want to be taking the history, brief history, then examine the patient and then investigate the patient. Then we want to do ABC of resuscitation, adequate fluid replacement and hydration, nutrition, pain management, antibiotics if indicated, treat underlying cause, and then surgery if there's need. So for ABC of resuscitation, in the emergency ward, we want to check the patient's airway to be sure that it's patent. Then they told us from this question that the patient has oxygen saturation of 90%, so we want to commence intranasal oxygen. Then we want to secure IV access and set a wide bore cannula, and then we will take all the investigations that are necessary, like the serum blood urea nitrogen, the hematocrit level, full blood count, liver function test. These are things that will help us prognosticate this patient. So we want to take it at this point. Then we go on to fluid therapy. It has been noted that early aggressive fluid resuscitation is actually the foundation of acute pancreatitis. However, some studies say that patients that you aggressively manage with fluid tend to develop fluid overload. So it's been suggested that in patients like this, we have the dose that we give. So for the fluid resuscitation, the ideal fluid is actually IV crystalloids, either Ringer's lactate or normal saline. However, Ringer's lactate has been shown to be superior to normal saline in the sense that it reduces serum C-reactive protein. So it helps in reducing the systemic inflammation that is happening in this patient. And also normal saline is at disadvantage because it has been shown that it increases the risk of having hyperchloremic metabolic acidosis when you use large volume of fluid. So Ringer's lactate is the preferred choice and is given with an initial bolus of 15 to 20 ml per kg. Then you maintain the patient with 3 ml per kg per hour. So approximately the patient should be getting 250 to 500 ml per hour in the first 24 hours if there's no contraindication to fluid. So in this first 24 hours, now we have to be reassessing the patient every 4 to 6 hours. So we'll pass a urethral catheter to monitor urine output. We want the patient to at least pass 0.5, greater than 0.5 ml per kg per hour of urine. Then also we will monitor the patient's serum blood urea nitrogen and also the hematocrit. So if we are resuscitating the patient and the bond value is increasing or the hematocrit is increasing, that means we are not resuscitating enough. So we have to adjust the fluid. But if these two values are, these two parameters are decreasing, then we are happy that we are winning. But if there's no response, that means there's a high likelihood of multi-organ dysfunction. So we have to change level. And in this patient, actually, on presentation, we can use some severity scores to actually know whether this patient is having a severe disease. And if they meet the score, we have the Ramsey score. Those are the ones you can use in the first 24 hours of admission. We have the Ramsey score, we have the BSAP, and we have the Apache 2. However, the BSAP is actually the fastest because it has 5 parameters. So I will discuss about that later. Then for the nutrition, it's advised that if patients have abdominal pain, vomiting, nausea, ileus, the patient should be kept on Neopa oral. However, in mild pancreatitis, it's advised that patients should commence feeding with low fat and low residue diet, and then later we can convert them to regular consistency. But in severe pancreatitis or in patients that cannot take orally, we can actually use nasogastric feeding, or we can do nasojejunal feeding compared to parenteral feeding. And it has been shown that nasojejunal feeding is superior to parenteral feeding, parenteral nutrition. But however, for this nasojejunal feeding, we need an interventional radiologist to come and help, and it's cheaper when compared to parenteral. And it also has an advantage of minimizing bacterial translocation in the patient. Then for pain management, it is advised that we use the WHO analgesic ladder, where we start from step 1 using NSAIDs and we escalate up the ladder using highly potent opioids, examples like fentanyl. However, previous studies showed that opioids are no good in these patients because it worsens or triggers spasm of the sphincter of Oddi. But presently, it has been advised that it can be used. Then antibiotics in these patients. If the patient normally patients don't need antibiotics, but when we have suspicion of infection, for example, if it's a necrolizing pancreatitis that is infected, then patients can be commenced on antibiotics, usually the carbapenems or the fluoroquinolones. However, the carbapenems have been shown to be superior to fluoroquinolones because they have better tissue penetration. Then in this patient, we want to look for the underlying cause and also treat. So since gallstone pancreatitis is the commonest, we want to ask for history surrounding that. And if that's the cause, we want to do early cholecystectomy or early ERCP for any biliary obstruction. Then for hypertriglyceridemia, the patient can benefit from plasmapheresis or insulin drip with or without glucose. Then if it's due to alcohol, even though the patient now is on admission, so we can't talk about it now, but this is what we'll keep in mind when we are discharging the patients on how to stop alcohol intake. If it's acute autoimmune pancreatitis, glucocorticoids, then for post-ERCP, we can actually do a pancreatic duct stenting or rectal endometriosis. Then if there's any infection we want to treat appropriately, then also stop inciting drugs if possible. Then for surgery, surgery is usually indicated for severe pancreatitis, usually if there's a collection or there's a necrosis. So for these patients, we can do an image-guided percutaneous aspiration, or we can do a necrosectomy if there's presence of necrosis. Now I'll be talking about...
Dr. Kalagi.
Yes, sir.
Yes, so I think the time is fast spent, so maybe the slide will come later. I think somebody has presented severe pancreatitis before, but so that we can give time for people to contribute and ask questions. So if there is any question relating to your slides, you can refer to your slides. Thank you very much for the wonderful presentation. So the class is open for comments, contribution, questions. Any questions, any contributions? You can raise your hand or you can type in the chat box. Okay, Dr. Success. You can go ahead.
Okay, good morning, Dr. Chris, for that lucid presentation. Before I make my comment, I want to ask maybe from you one or two clarification. The first one is maybe a problem of nomenclature. Is it supposed to be severe acute pancreatitis or acute severe pancreatitis?
Uh, I think it's acute severe pancreatitis because I know that acute pancreatitis is classified into mild, moderate, severe. So I think it's
Okay, so I'm just saying that
severe.
because in your slides you wrote severe, so that you can. Then I want to ask again, what is the most appropriate test when we are setting for severity of pancreatitis? Which of them is the most appropriate?
Is contrast enhanced CT of the
No,
abdomen.
most appropriate. Sorry, not test. In your diagnostic, those prognostic severity, yeah. So those severity scores, which of them is the most appropriate? Sorry.
Okay.
You
The
called
most
this up, yeah.
Yes.
But
I think
which of them?
I think it's Apache 2 because
Okay.
it's more sensitive. But they said BSAF is more specific.
Okay, because I know there was a question that came up like that. So I was just wondering which. Then I want to say something that
Apache is more validated than the other scores, Ransin or BSAP. BSAP is a quick assessment. Can do that at your bedside, and you can assess the patient. Then there's the Ransin's criteria also. So, but Apache is the most validated scoring system.
validated. Okay. Thank you so much. Just a quick contribution. About the nutrition. We are thinking that because oral feeding will actually, so we rest the ball and as much as possible avoid oral feeding. The pathogenesis of pancreatitis, there's autodigestion. So when the patient takes anything orally, it stimulates the release of this enzyme. Okay, so further worsening the condition. So as much as possible, you want to rest the boil until the you are sure that the pancreatitis has resolved. Then I usually like using the mnemonic for the courses I get smashed, so that it may just be easier for us to take in. The I is idiopathic or ischemic. G is gallstone, of course, which is the commonest. Ethanol, alcohol, trauma, steroid, malignancy, autoimmune. The H is hyperlipidemia, hypothermia, hypercalcemia. Of course, the ERCP and the medications. Okay, medications such as tetracycline, valproic acid, azothioprine, and so on. Thank you so much. Just to end that, there are some complications that we can be or may be associated with acute pancreatitis, and include pancreatitis, multi-organ failure, encephalopathy, GIC, KIS, SIRS, and so on. So these are just my small contributions. Thank you so much for the lucid presentation. Thank you.
Yeah, thank you, Dr. Success, for your contribution. And also, for the nutrition also, even though we want to rest the ball, but studies have shown that early feeding also it's good to institute early feeding between 24 and 36 hours for those that can tolerate orally. And for those that cannot tolerate orally, you want to place in a nasovaginal, feeding tube. Okay, so early feeding also has, especially in mild pancreatitis, so it's still considered safe as it doesn't exacerbate the symptoms of acute pancreatitis. Any other comment, any contributions? Okay. Dr. Ekele, I say thanks so much for the very, please, can you show the scoring system? Okay, so those are the scoring system. Yeah. Those are the scoring system. The Ransin, the BSAP, the Apache. Any other comments, any other contributions?
Dr. Atta, are you done with all the comments and questions in the chat box?
Yeah, I think I'm not seeing. Yeah, just only Dr. Ekele that's
Okay.
for this. Yes.
It was quite a lucid presentation from Dr. Lagbe, and then thank you, Dr. Atatu, for coming. Chief Cookim, I don't know if you want to fine-tune anything, you want to add anything. Your children are repping you well.
Good morning. No, I think it was beautifully delivered. I think so. The only thing I don't know, to adjust that nomenclature thing, I think the condition is acute pancreatitis. So whatever you're using to qualify it should come before the acute pancreatitis. So it's either mild acute pancreatitis or moderate or severe acute, not acute severe pancreatitis. That's just my own.
Okay, ma.
Thank you.
Thank you, ma. So, Dr. Olagbe, you heard then Chief Cookie. So I think you're in order from what you said.
Yes, ma. Yes, ma.
So we'll leave it at that. Thank you so much. Thank you so much, Dr. Olagbe. We appreciate you. Dr. Atta, thank you. The first presenter. And I don't know why the name is difficult for me to pronounce. Thank you so much. We appreciate your time and presentation. Everyone that contributed, thank you.